Picture this. You're examining a patient. You ask them to squeeze your hand and their other hand squeezes too, all on its own. What on earth does that tell you? Well, that's what we call a mirror movement. It's this really fascinating clinical sign that can be just a normal quirk in a developing brain, or it can be a huge clue pointing to a serious neurological condition. So today, we're going to break it all down. What it is, why it happens, and what it really means when you see it in your patients.
So here's our game plan. We'll kick things off by defining what mirror movements actually are. Then, we're going to step right onto the ward with a clinical case. After that, we'll get into the nitty-gritty of the exam and the underlying causes, and we'll wrap it all up with some high-yield clinical pearls and a quick knowledge check to make sure it all sticks.
All right, first things first. Let's get a really solid, crystal clear idea of what we're talking about when we say mirror movements.
So have you ever actually seen this? Maybe a little kid, totally focused on drawing or writing, and you notice their other hand is kind of mimicking the same motions. That involuntary copying, that is exactly what we're talking about. For a child, that's often a normal part of development. But when we see that same sign in an adult patient, well, that tells a very different story.
So the official definition is involuntary movements in one hand that mirror the intentional voluntary movements in the opposite hand. And the key word here, the one you've got to remember, is involuntary. The patient is not trying to do this. This tells us there's some kind of crosstalk happening in the brain's motor pathways that, frankly, shouldn't be there. And figuring out why is absolutely crucial.
Okay, theory is great, but let's see this in the real world. We're heading to the ward to meet a patient where this sign becomes a really important piece of the whole diagnostic puzzle.
Let me introduce you to Mr. Chen. He's a 68-year-old gentleman who's just been admitted to the stroke unit. This is a super common scenario, so you'll definitely want to pay close attention to his case.
So Mr. Chen's story is that he's had a recent ischemic stroke. And that stroke has left him with weakness on his left side, what we call clinically a left hemiparesis. This means a very specific part of his brain's motor cortex, the area that controls movement, has been damaged. This context is the key to understanding everything we're about to see.
So, we suspect Mr. Chen might have mirror movements. How do we actually confirm it? You know, the beautiful thing about this sign is that you can test for it with a super simple bedside maneuver. No fancy equipment, no expensive scans, just your hands and some keen observation. The technique is elegant in its simplicity. First, you place your fingers into both of the patient's hands. Then, you give a very clear instruction. Something like, Mr. Chen, I want you to squeeze my fingers as hard as you can, but only with your weak left hand. Then, your job is to watch his right hand like a hawk. What we're doing is forcing him to send a really powerful motor command from that damaged hemisphere. We're looking to see if that signal is so strong that it kind of spills over to the other side. And here it is. This is the absolute key, high-yield point that trips up so many students. The mirror movement actually appears in the unaffected hand. Now, why would that be? Well, the theory is that the damaged motor cortex has lost some of its normal ability to inhibit or put the brakes on signals. So when this huge signal is sent to the weak hand, the usual brakes that stop it from crossing over, they're just not working. That signal bleeds over and activates the healthy side. You've got to remember that for your exams.
Okay, so we found the sign in Mr. Chen, and in his case, it's pretty clearly pointing to his stroke. But, and this is a big but, mirror movements aren't always a bad thing. So let's decode the causes and figure out how you can tell the difference between a normal finding and a serious red flag.
So you can basically put these into two big buckets, physiological versus pathological. In little kids, those big motor pathways from the brain down the spinal cord, the corticospinal tracts, they aren't fully myelinated yet. Think of it like wires that don't have all their insulation. So it's totally normal for some signal to cross over. But in an adult, that wiring should be fully insulated and developed. So if you see this sign in an adult, it tells you that something has gone wrong with that circuitry.
So when we do see mirror movements in an adult, what should be on our differential diagnosis? Well, as you can see, it's a pretty broad list. It includes big structural problems like a stroke or agenesis of the corpus callosum. That's a condition where the main bridge connecting the two brain hemispheres just doesn't form correctly. But it also includes things like neurodegenerative conditions like Parkinson's disease and even certain genetic syndromes. The common theme here is some kind of disruption to the brain's motor wiring.
All right, let's boil all of this information down into some super high-yield clinical pearls. These are the absolute key takeaways you're going to want to have locked and loaded for your exams and when you're on the wards. Okay, first mini case. You've got a 5-year-old. Parents are worried because his left hand clenches when he writes with his right. What's your thought process here? Well, the biggest clue, the absolute giveaway, is his age. At 5 years old, that nervous system is still a work in progress. This is almost certainly a normal physiological finding. The right move is to just reassure the parents.
Now here's a classic for your board exams. An adult with mirror movements plus anosmia, the complete inability to smell. That specific combination should make a light bulb go off in your head for one diagnosis, Kalman syndrome. It's a genetic disorder where certain neurons just don't migrate to the right place during development, including the ones for smell and the ones that control hormones.
Let's wrap this section up with the key clinical principles. First, mirror movements are a really unique sign. Not much else looks like it. Second, if you see this in an adult, stroke should be right at the top of your differential. And third, remember that we don't really treat the mirror movements themselves. Our job is to diagnose and treat the underlying condition that's causing them.
Okay, time to see if everything we've talked about has really sunk in. Let's do a few quick questions to solidify these concepts.
And the answer is the unaffected hand. Remember our reasoning? That strong motor signal to the weak side spills over because of a loss of inhibition from the damaged side of the brain.
Nope, absolutely not. In a young child, this is usually a totally normal physiological finding. It's just a sign of an immature nervous system, and it's something they're very likely to just grow out of. Hopefully you've got a few that came to mind right away. Besides stroke, you could have mentioned Parkinson's disease, Kalman syndrome, essential tremor, or a big structural issue like agenesis of the corpus callosum.
And here's a quick summary table, perfect for some last-minute revision. Look, if you only take one thing away from this whole session, make it that last row. In a patient with weakness from a stroke, the mirror movement shows up in the unaffected hand. That is such a critical, high-yield clinical sign. So, we end right where we started. A simple, involuntary twitch of a hand, and yet it opens this incredible window into the brain's complex highways. It reveals this silent crosstalk that's always happening between our two hemispheres, and it's just a great reminder that even the simplest action we take is the result of an unbelievably intricate and finely tuned system.